So everyone is present here. So the topic for today is case-based discussion on meningitis. And the case examiners we have here is Dr. D.S.N. Rao. He is a head of department critical care at Samford Hospital, Ranchi. We also have Dr. Reshu Gupta ma'am as a case examiner. She is a senior consultant and HOD at critical care medicine at Health City Hospital, Guwahati. Here we have our moderator, Dr. Rakesh Periwal, who is a consultant at Apollo Hospital, Guwahati. And here we have the case presenter, Dr. TATONGTEMSU LONGCHAR. So shall we start?
Yes.
Thank you very much. A very good evening to everyone. I'm presenting the case of a 32-year-old female, a resident of Kamrup, Assam, who presented with chief complaints of fever for 3 days, headache with multiple episodes of vomiting for 1 day, and altered sensorium since morning. History of present illness. The fever was ongoing for the past 3 days, which was continuous in nature. There was no diurnal variation and was not associated with chills or fever, and was relieved by taking medication. She had headache for the past 1 day, which was continuous in nature and increasing in severity, dull aching in nature, and confined to the frontal region. It was also associated with multiple episodes of vomiting, which was non-projectile. She also had altered sensorium with decreased responsiveness since morning, which was acute in onset. There was no history of trauma or seizure activity, substance use, or medication. There was no history of ear pain or air discharge. There was no history of trouble. She had a surgical history of right frontal mini craniotomy for colloid cyst excision, which was done 1 year back. And she also had a surgical history of cribriform plate repair for CSF leak. She had a history of bacterial meningitis, which was Streptococcus pneumoniae 3 months back. In her personal history, she is a housewife, vegetarian by diet, and had a regular bowel and bladder habits. She had no addiction, and there was no significant family history. In her general physical examination, she was normal built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema was present. Vitals on presentation was pulse was at 139 per minute. Blood pressure was at 130 by 80 mm of mercury. SpO2 of 98% on room air. Temperature of 100 degree Fahrenheit. And random blood sugar of 145 milligram per deciliter. On her central nervous system examination, patient was oriented to time, place, and person, but drowsy at the time of presentation. Bilateral pupils were normal size and reacting to light. Bilateral plantar reflexes were flexion. There was neck rigidity and Kernick signs were positive, and there was no facial deviation or focal neurological deficits. On systemic examination, in the cardiovascular system, there was regular heart sounds with no murmur. Respiratory system, bilateral air entry was equal with no added sounds. And in her gastrointestinal system, it was soft. There was no organomegaly, and bowel sounds were present. Before admission to our hospital, she was admitted to another hospital where her total leukocyte count were 17,400, and she was started on injection ceftriaxone. Then the patient was then shifted to our hospital for further management. So we made a list of differential diagnoses. In the infective one, we had a differential of meningitis, brain abscess, septic encephalopathy, and in the non-infective, we had the subarachnoid hemorrhage. Initial management on day 1, her airway, breathing, and circulation were secured. Intravenous access with 18-gauge cannula, and ABG showed a pH of 7.388, PO2 of 87, PCO2 of 33, and lactate of 5.9, and a bicarb of 20. Random blood sugar was 147 milligram per deciliter. Routine investigations or CBC, complete blood count, renal function test, liver function test, coagulation profile, tropical fever, cultures of blood and urine were sent. The MRI brain showed post-surgical changes in right frontal with minimal blooming in right frontal cortical and subcortical region with leptomeningeal enhancement. Lumbar puncture was done and CSF analysis was sent. The routine investigations, the significance were potassium was on the lower side of 2.8 and tropical fever came up negative and the viral markers were negative. We started her on injection ceftriaxone 2 gram 12 hourly, injection vancomycin 1 gram 12 hourly, and injection dexamethasone 8 milligram 8 hourly. On day 2, we received the CSF analysis report where the total white count was around 2,800. Neutrophils were 97.3%, lymphocytes were 2.7, and protein was 205, and glucose of 10. So we added injection meropenem 2 gram IV 8 hourly, and due to the decreasing level of GCS and aldosterone patient, we intubated the patient and she was mechanically ventilated. But unfortunately, patient went into shock. We inserted the central venous line and arterial line, and we started her on injection noradrenaline and also on injection vasopressin. And unfortunately, her condition deteriorated and we lost the patient on the same day, that is day 2 of our admission, sir.
Hello, thank you, Temps, for the presentation. The case remains open. I have
We have here Dr. D.S.N. Rao as our examiner. So you may start.
Yeah, sir is not there on the, he's not visible. Is he there? He can take over?
Yes, yes.
Yeah.
Good evening, all. Am I audible?
Yes.
Yes, sir.
Good presentation. Yes, it was very clear. But one, two things just needed to. I'm not asking question as an examiner. I just want to discuss and clear some points where
Sure.
maybe something different would have been done. Seeing the first ABG, your lactate was 5.9.
Yes, sir.
Right. So what did that signify? Lactate 5.9. What came into your mind first, and how did you react to it? And
Sir,
you did not show a serial ABG whether the lactate is increasing or decreasing.
yes, sir. Actually, lactate increase in the lactate might be a sign of tissue hyperperfusion, sir. So we did a ultrasound guided IVC monitoring, and yes, sir, and it was collapsible. Around 40 to 50% was collapsible in chicks, so we resuscitated her for that, sir. We gave a IV bolus of 500 ml of Ringer's lactate, and we did a maintenance of 80 ml per hour key subject. We started the injection RLs.
So, did you check for the repeat ABG after that before the patient succumbed to its whatever the infective cause?
Yes, sir. Actually, after the serial ABG, we checked it, and though the IVC was distended, the lactate keep on serially increasing, and it went up to 10, sir.
That means that even if, although initially you thought that dehydration may be the cause of hyperlactatemia, in
Yes,
spite
sir.
of fluid resuscitation, your lactate kept on increasing.
Yes, sir.
That means the patient was not responding to the treatment.
Yes.
So, didn't you think it otherwise means some other means to tackle it? You had added dexamethasone, you had a good antibiotic coverage. Anything more because of the increasing lactate? Did you do a echocardiography seeing maybe she might have landed into a septic cardiomyopathy sort of a thing? Because in cases of reduced ejection fraction also you may have an increased lactate.
Uh,
So did you do an echo screening?
Echo screening was done. We just did an eyeballing. So actually, cardiac
Yes.
consultation was done, and
Hmm.
eyeballing was just we did an 2D eyeballing from the ICU,
Hmm.
and it didn't show much of a left ventricular dysfunction or kind of like a regional wall motion abnormality was not seen actually, sir.
Right. Okay. If others could please intervene, what could have been done differently so that the lactate would not have increased? That still lies unanswered to me. And I also means want to discuss why did this lactate increase? Whether the in septic focus was not addressed to properly, fluid maybe yes. So these are. What about the LFT? LFT was normal because
LFT was
something.
not there. So actually, prior to her admission to our hospital, she was admitted in another hospital, and where the TLC count showed around 70,400, and injection ceftriaxone was started in that hospital. Then on the next day, when we did the TLC count, and it was around 9,050, like within a period of 1 day, sir, a few days, sir.
Hmm. You've given ceftriaxone, meropenem, and vancomycin, no?
Yes, sir. On the first day, we started her on ceftriaxone, 2 grams, 12 hourly. Injection
Hmm.
vancomycin, 1 gram, 12 hourly. And on the
Hmm.
second day, after the CSF report came to us,
Hmm.
we shifted her back to injection meropenem, sir.
So viral meningitis was not one of the differentials.
Uh, so we didn't keep the viral in our differentials. It could have been a possible cause, but given the decrease in the TLC counts, we suspect it to be more of a bacterial, sir.
Because antibiotic coverage was seems to be adequate, covering all everything, all the antibiotics which penetrate the blood-brain barrier.
Yes, sir.
But still the patient could not survive means there was something missing out of this. There's some puzzle means some missing thing which was not addressed to, because normally she had a CSF leak also
Yes,
surgery.
sir. Yes, sir. She had a surgery done, which was done 1 year back. She had a colloid cyst in the frontal region for which the excision was done. Then after that, she developed CSF leak for which cribriform plate repair was done. But in the subsequent cysternovanography, it showed no CSF leakage, sir.
So this time there was no CSF leakage from that.
Yes, sir. Yes, sir.
Okay, ठीक है, thank you.
Thank you, sir.
Hello, we had heard from Dr. Rao. The CSF picture was suggestive of bacterial meningitis because one of the most remarkable things was the low sugar levels in the CSF, which is absolutely something very strongly related to bacterial meningitis. Well, I think among all the CSF parameters, the counts, the differentials, the protein, the sugar, one of the most important ones is the sugar levels. If it is low, then it is almost invariably bacterial meningitis. Or if you are able to find the organism on gram stain, it is very highly attributable to meningitis. Or if you can do biochemical tests, antigen-based tests or PCR-based tests, and if you find an organism, then you can directly attribute. So, but as Dr. Rao said, yes, something went wrong in this patient. The patient's urine output was maintained. The patient's blood pressure was fairly maintained. We had placed an arterial line fairly early. Other than the lactate, the only other thing was a persistent tachycardia and high-grade fever. She has a tachycardia of 150 all throughout, which somehow didn't settle down with cooling, with paracetamol, with steroids. She remained
Okay.
restless actually the first 12 hours or so, and we actually electively intubated her without any fuss
Okay.
because her sensorium was something which she was losing. After
Okay.
we intubated, maybe within 2-3 hours, the shock started in terms of the BP falling. Started, she became oliguric. and she
Mm.
really had a very bad downhill course. Within the second day evening, even though we had identified the disease almost within 2 hours of arrival, she already had got an injection, ceftriaxone, which was great before at the onset of symptoms. So antibiotic initiation was also very timely. And
Mm.
thereafter, we did the lumbar puncture in the evening. We had the basic counts and proteins and biochemicals within 2 hours, and we actually knew that we were dealing definitely with bacterial meningitis. The only other thing was what else could have caused such a downhill course. I did a optic nerve sheath diameter
Yeah.
testing then. It was
Mm-hmm.
elevated. So the raised ICP was there. There was
I
no
see.
question. It was 6 mm.
Okay.
So
Yes.
we had thought maybe many of the manifestations, especially the sensorium going down, could be due
Mm-hmm.
to raised ICP, and also
Yes.
the hemodynamic disturbance could be due to centrally driven, no, raised ICP related. Could be because at certain point of time her blood pressure was 200 when we had
Okay.
placed an arterial
Ah.
line, which was really on the extreme side,
Okay.
and
Okay.
within hours her blood pressure fell down to 100.
Must
And that
fluctuating
blood pressure, once
hemodynamics.
it fell down, yes. So I think something like the triple response that we see, but no bradycardia, no bradycardia. There was only
Okay.
tachycardia, high blood pressure to
Mm-hmm.
begin with. So we did not think of this, hemodynamic related lactate elevation, honestly. As
Mm-hmm.
Dr. Tem said, we did a bedside basic echo. It was absolutely normal. The lung also we saw, lungs were normal. The optic nerves we saw, it was 6 mm at the initial examination, although we did not repeat the examination because by then we knew that the only thing we had was giving steroids and antibiotics.
Yes.
Why the antibiotic was changed next day, you can ask, was because she had an exposure to an antibiotic
Yeah.
3 months back. And that
Yes.
was, but that was a sensitive streptococcus. She was also admitted
Mm.
in our hospital on the
Mm-hmm.
previous occasion.
Mm.
And probably at that point of time, we thought the leak or maybe a rent somewhere in the coverings of the brain must have caused the infection because she had a history of a colloidal surgery for a colloidal cyst. And
Mm-hmm.
she had some symptoms suggestive of CSF leakage then. She had running
Okay.
nose. So we had sent her, and as he said, she actually went ahead. They did a cribriform repair, and very surprisingly, only 1 week before, she had gone for a follow-up, where she got an MR cysternography, which revealed
Mm.
absolutely normal. And there, you could also say no ear illness, nothing in the mastoids, nothing in the base of the brain, which could have led to the breach or maybe infection. Suspecting, but symptoms were very suggestive of meningitis. So we
Yeah.
did LP at the fastest we could do, just at arrival, even
Yeah.
without
Yeah.
getting the scan done, because I thought
Mm.
there was no time to get a scan done.
No. 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 Not at all.
We did whatever could. It is really, why we had put up a discussion is that is clear-cut bacterial meningitis, and in spite of starting her on appropriate antibiotic, I would say we lost the patient, which was very sad, and very young patient, only I think 31
32
years or
years.
something.
32, sir.
Yeah. No comorbidities other than the previous meningitis that she had. So I also
Mm-hmm.
had the same question, what else could we have done?
Did you
Regarding
get a
completeness of the
procalcitonin done, Dr. Rakesh?
procalcitonin was elevated.
Procalcitonin was
But
elevated.
procalcitonin elevation is known to occur in bacterial meningitis. It
Yes.
is
Yes.
something which can distinguish between viral or what you call as aseptic meningitis and bacterial.
Mm.
They say if it is
The
higher, the chance of bacterial meningitis is
other
very,
sort of
very high.
meningitis ruled out.
Very, very high. So,
Uh,
but the shock was something which really disturbed us. We did tube her also. It was not that she aspirated or she had a cardiac event or a CPR.
mm.
Nothing happened. We just
Mm.
intubated her because she was very restless and her airways didn't look as protected, and her blood pressure and this pulse were always on the higher side, 150, 160 tachycardia, and the BP around 180 to 200, which we thought was all driven by sympathetic drive or maybe raised ICP. That we could not, but that was one thing which made us to intubate her early morning next day because I was there. And
Okay.
then within 4 or 5 hours of that, she started sinking. By the late afternoon, we already lost her. Lines were in place. Whatever guided resuscitation we could do, it was in place. So, but this is very interesting because in meningitis, if someone has to die, they die within 48 hours. That's it. If they
Mm.
survive that time, then they invariably make a recovery without any deficit most of the time. Most of the time. And
And
if
such young
Patient is not
patients.
improving within 2 hours.
2 days, sorry, then you really got to think if there is a complication like a abscess formation, or if there is a resistant bug, or
Mm.
is there a complication like hydrocephalus or an infarct somewhere, or maybe dilatation of the ventricles or raised ICP is still persisting. So we generally get a very predictable response in bacterial meningitis, but this was
Yes,
someone
yes.
whom we lost within the first 48 hours. So the other side also remains true that probably in the first 48 hours, we don't have much other than diagnosing early and starting empirical antibiotics early, which I think we did. We sent the cultures, relevant cultures, all biochemical markers. We did all the serological tests for tropical infections, all were negative. And we did the gram stain for the CSF, which did not come out to be positive. The culture of the CSF, I could not.
The death has occurred very recently.
Mm.
So we do not know, but I would like to look up what was the culture. She died also. We just forgot to collect the cultures. That's the only thing. The curiosity, could it have been a resistant bug and with a
Yeah,
breach in the
maybe a
brain? Could
culture
it have
culture
been?
sensitive. The sensitive
Yes, but
antibiotics
sir,
may have been different.
yes, but she died the second day, so there was no way
Oh
we could
yeah,
have got a culture and we could have
yes,
kind of changed our therapy. There was no growth till then. There was no growth.
no growth. But the choice of antibiotics were quite logical and
Okay,
appropriate
yes,
it
yes,
seems.
yes. And because she was started already on a ceftriaxone, we thought let's continue with the dose. Let's add vancomycin. That's the only thing that we did.
Mm-hmm.
I think in the chat box, if people have any questions, we can answer. Okay,
Did you do
there are certain, yeah.
the malarial parasite?
Yes, negative, negative, negative.
Negative.
Malaria, scrub, typhoid, dengue, we did serologies, so all were negative.
All were negative. ठीक है. Okay.
Yeah.
Anyone else if they
What?
have any?
Yes, they have asked what about Neisseria meningitis? Yes, yes. If you get a gram-negative diplococci on gram stain immediately, gram stain should be sent in all CSF samples. I can just give you a little bit on CSF. That when you send CSF, you please send cultures in everybody who is CSF culture, in everybody who is suspected to have bacterial meningitis. The CSF culture yield is very high, 60 to 80%. And you always do a gram stain, because if the gram stain shows something, it can give you direction, the fastest. And then if you have the availability, you should send, some people can disagree or agree, but you should send tests which pick up organisms by PCR or by antigen based tests, because most of them are well validated and most of them give a lot of clue. Like Cryptococcus is almost a standard in HIV to send. But you can send a biofire panel, it comes by that name in India, in which you have most important viruses, herpes 1, 2, 6. Then you have the herpes zoster, varicella zoster, enterovirus. Then among the major organisms, Streptococcus pneumoniae, Haemophilus influenzae, and
And the results come early. I think
monocytogens.
within
You
4 hours.
all get antigen tests based on them, and they're fairly reliable. In fungus, you get Cryptococcus. So I think that is what we routinely send. In this
Mm-hmm.
patient, we could not send because she came late in the evening. So at that time, that sample transfer to that lab doesn't happen. So we thought
Yes.
if at all necessary, but we already thought it was bacterial meningitis. Already were not looking for viruses anymore. So we thought we will very, very well wait for culture and see. But I think that is one test which at the fastest can give you some hint about organisms. But other than that, I do not know how you can know faster than a culture what
Yes, yes,
exactly was
agree.
the cause of
Mm.
meningitis. Would you like to take autoimmune encephalitis? If anyone is there to take, Dr. Rao, any biofire we answered. See, somebody is putting the
See,
question and it's already.
autoimmune. See, my personal view is autoimmune meningitis is a diagnosis of exclusion. When other bacterial and viral parameters are ruled out, she's a yes, she was a young lady, may be prone to autoimmune, but her previous admission and all that, maybe her vasculitis panel or autoimmune things may have been done, or if not, I do not know, means first, when there is such a strong suspicion of bacterial meningitis and other biochemical parameters pointing out to it, autoimmune meningitis, maybe it might be a diagnosis of us if the patient survives and still has tachycardia, fever. So maybe thinking of autoimmune, even if it was a autoimmune meningitis, you had added dexona, the steroids, which are the thing, the treatment of choice. So
See, somebody has written about acyclovir initially. Well, you can give acyclovir initially if your suspicion for a viral meningitis or encephalitis is very high. But with a blood sugar levels, CSF sugar level of 10, it is ruled out. Almost you can say. Nobody is going to catch you. And the counts, if you look at 2000, it is very unusual to find in viral meningitis. It could be a little bit elevated, especially encephalitis, meningitis, whatever. And the protein levels, okay, it might be elevated, but not so florid. But if you have a patient who has lateralizing signs, whom you could do an imaging and find some changes in the brain parenchyma suggestive of encephalitis, if you have a CSF in which there is a little elevation of counts, maybe little elevation in proteins, and a sugar which is normal, you can start acyclovir empirically. Yes, you can do that. But always send CSF for herpes PCR, because the pickup rates of herpes PCR is 90% or more. So it is going to give you a very good yield. So if you send that, and if it comes out to be negative and the clinical picture is more suggestive of bacterial meningitis, then acyclovir has no role. But as an initial empiric, undifferentiated encephalitis, meningitis, that also you cannot distinguish. Yes, in this patient we say meningitis, but because there was altered sense, you can also say encephalitis, or you better say meningoencephalitis, like it happens in TB. And regarding autoimmune encephalitis, the course is very, very fast. It's very unusual to have such a rapid downhill course in autoimmune encephalitis. They more present with few days of symptoms or maybe weeks of symptoms, and generally psychiatric symptoms or some vague symptoms or symptoms which are multifocal, and then they get admitted, and you don't see such downhill course where they become septic and hypotensive and there is a lactate elevation and they die the second day. That is not the usual case. But yes, autoimmune encephalitis, middle-aged and elderly, non-explained neurological symptoms, a slightly chronic history, you should always send biomarkers both in the CSF and in the blood. That you can do. Role of CSF lactate, somebody?
Neglidia meningitis.
Any evidence for intrathecal antibiotic is what they have asked. I think anyone else from the faculty who is here? Okay, I can't see in the list. I'll take that, no problem. See, as regards to intrathecal antibiotic,
with the Neglidia, did you check for the Neglidia meningitis?
The CSF gram stain was negative. Beyond that, we did not get anything because the patient died only. I don't have the culture reports.
Because one of my school buddy, he died with Neglidia. It is also very, very fast progression of disease. In 3 days, he died. It's a very dangerous sort of scenario. Young patients are involved with treatiform prasia, and usually the history is swimming pool, and that's how they got this Neglidia into the brain, and then they die from meningitis.
Okay, I don't have any idea about these. I will have to read up to look what are the manifestations. Somebody asked about the role for intrathecal antibiotic. Very simple, intrathecal antibiotic only when you have a resistant organism, which is proven by cultures, number one. Number two is they always are given by a port in the ventricle. Ventriculostomy should be there. So they are generally for patients who have neurosurgical problems, because nobody is going to put a port to give an intrathecal antibiotic. Unlikely. Number three is there are very few agents to choose from which have shown to be used in the CSF safely, because safety is also an issue. It's vancomycin, the aminoglycosides like amikacin and gentamicin, and polymyxin and colistin, most commonly used antibiotics. And they are always used with systemic antibiotics. So systemic antibiotics will always be there. Add intrathecal if you have a ventriculostomy drain in place, and if you have isolated a resistant organism. See, intrathecal antibiotics can also have side effects because they achieve very high concentrations in the CSF and can be neurotoxic, especially the aminoglycosides. Any role CSF lactate? Yeah, CSF lactate, it is elevated. It is highly sensitive to bacterial meningitis. It can help you in picking up bacterial meningitis. Yeah, anybody has any query? Anything else we can take? Dr. Rao, if you'd like to answer the next one, if you're there.
Yes, I am there. What is the question,
Yes.
Dr. Rakesh?
Brain herniation post LP.
See, brain herniation post LP. When the MRI was done, it did not show anything regarding raised ICP, first of all. And secondly, what my personal experience says that the needle which we use, that is maybe of 25 or a 23. How much do you feel comfortable with the needle?
22 or 25, yeah. That size only.
So means with 2500% is there, means I have not seen any patients of a herniating brain post LP. And even if it was a herniation, uh, maybe the patient would have a bradycardia. Maybe she was totally tachycardia, the thing, and more of heart issues would have been there. I don't know, but until proved otherwise, I would feel that that was not the cause.
I think absolutely you picked it up, that brain herniation is generally maybe of historical interest, and it's unlikely to occur if there is no structural lesion presently. So if somebody doesn't have an abscess or a tumor, post LP herniation, okay, doesn't happen. Not written. And in some only patients who have had a neurosurgery before, or who have a SOL, or whom you have a high suspicion of having an abscess, or if they're immunocompromised, you should do a scan before doing an LP. Otherwise, the rule is you do an LP at arrival. It's with these 25 gauge needles, probably it's safe. But yes, the contraindications or maybe the cautions of doing LP are when you suspect that there could be herniation. And the causes I have already enlisted. So without those, it's unlikely. Role of CSF lactate, yes, for bacterial meningitis. What are the clues on initial presentation to DEXA, as it is more likely to help in bacterial only, are the counts? And you have to make the decision before you give the antibiotic, what to do. You have to give the dexamethasone beforehand. So 30 minutes before, we say, and then you start with antibiotics. The role of dexamethasone is only if it is started early, number one. And number two, the major benefits is in certain organisms, like in Streptococcus, it is shown to have benefit. In Haemophilus influenza-related bacterial meningitis, it is shown to have benefit. They have mainly been shown to have reduced incidence of hearing defects. So that is why we use dexamethasone. You can use 2-day therapy, something like 25 milligrams BD for 2 days, or you can use the 4-day therapy, in which we generally use 8 milligrams, 8 hourly, 6 hourly. 6 hourly is what is the standard. And if you don't use steroid, okay, there's no one to question you. The role for the use of steroids in adults with bacterial meningitis may have benefit, but it's not absolute. but it's almost a standard. I think Dr. Rao would also agree that you give steroids in almost all cases of bacterial meningitis.
Yes, yes, definitely. Means
Yes, yes. So he is
we
also of the
we
same
give it
opinion.
before the first dose of antibiotics. As
Antibiotic, true.
yes, as we see in cases of neurocystic sarcosis also, because we give the steroids first. We do not start with albendazole or the antiparasitic agent, because that may lead to the death and necrosis of the scolex, and that can lead to florid increase in intracranial pressure. For that, the patient may succumb. So we give dexamethasone, no question about that.
And then the next question we have put intrathecal antibiotic via putting epidural catheter in dural space. You can do whatever you want, but not recommended. We can do anything, but this is not absolutely not recommended. Let us be very clear that the antibiotic which you give through epidural catheters in dural space may not reach the place where it is needed. CSF circulation is such that you have to inject it in the ventricles for it to reach relevant spaces. So if you're talking about intrathecal antibiotics, it is only in relevance to the placement of a ventricular drain. All the papers and literature is basically based on a ventriculostomy and its placement. So this is a little bit, off label as you can use. Non-convulsive status epilepticus always possible. Yeah, the patient was absolutely conscious till the time we intubated her. We did not consider. She was getting a prophylactic anti-epileptic, but you can question whether it should be given or not. This is more like a policy of the hospital. We don't give prophylactic anti-epileptic to any patients with meningitis. Encephalitis, many of us are tempted to give. But I mean, it's a practice, but not a standard recommendation. And why we did not start with meropenem initially, because she was treated 3 months back. That's true. That could be, yes, he could have been given meropenem, but the point is, gram-negative organisms causing meningitis, only then we consider carbapenem as empiric therapy, true. And that is mainly in post-transplant patient or immunosuppressive patient. This was a young immunocompetent patient, and 3 months had already gone by actually. So maybe we did change the next day, but you can always question that again. You know that streptococcus, we are giving 2 antibiotics. Vancomycin is effective against streptococcus also. And the reason why we add vancomycin is to treat any streptococcus which could be ceftriaxone resistant. So the vancomycin gives us double cover. It covers against streptococcus and it covers against MRSA. So it gives you both the cover. So carbapenem, the copybook indication for using carbapenem is in patients who are immunosuppressed or who have a breach, whereby you consider, like in post-neurosurgical patients, where you consider that probably there could be a gram-negative hospital-acquired bug involved. Then you have those use of intravenous cholesterol. All these are reserved basically for patients who have hospital-acquired, probably hospital-acquired related. The time between this admission, the last admission, was actually more than 3 months. So we did not consider very strongly that it could be related to the exposure 3 months back. But yeah, you can start meropenem or you may give ceftriaxone. High dose carbapenem, vancomycin early in the previous could save her life according to SSC. Oh, I don't know. I have not seen any recommendations of using carbapenem and vancomycin. We are talking, let us not get confused between sepsis and bacterial. This is bacterial meningitis. Bacterial meningitis can present with everything like sepsis, but it's a localized brain infection which you have to treat. It is not another patient who has come with shock and maybe a pneumonia or maybe a GI infection or a urine infection. Then you have to cover empirically gram-negative organisms. Even in pneumonia, I don't need to cover. Only in hospital-acquired pneumonia, traditionally we cover. But in bacterial meningitis, you will never find anywhere mention about the use of meropenem initially. You will not find in any guideline. Secondly, you can use ceftazidime if it's a neurosurgical patient. So in all contexts, we talk about mostly neurosurgical patients in whom there is a breach in the brain parenchyma, or if there is a drain in place, or there is an intervention which is going on, or certain invasive leads are placed in the brain. In those patients, yes, but in others, no. Antibiotics which we can repeat, okay, I repeat, it's gentamicin, amikacin, Vancomycin, colistin, polymyxin, and somebody gave carbapenem. Oh, you can use carbapenem. The literature with carbapenem is very little, but these are the ones which are most commonly given. Aminoglycosides, the colistin group, and vancomycin. Accidental intrathecal loading, very, very unlikely. Very, very unlikely. Because you always draw and then you give a local. You don't inadvertently give a local. I mean, you can make any kind of mistake, but this is the most unlikely one. Vancomycin is the best drug, Dr. Rao, yes? Both of us, only vancomycin? I think there is nothing to replace vancomycin.
Yes, because the brain penetration is also quite good. And if you see the most common organisms causing meningitis, they are of the streptococcus and or maybe some gram positive organisms also, with all probabilities. Yes, only if you get a gram negative the CSF culture or a gram stain, then we can add definitely. But initially, ceftriaxone, vancomycin, these are the initial, because now we are thinking retrospectively that what could have been done differently. But when you get the patient initially, you will think of the common things first. You will not think of the rare things which might occur. So yes, vancomycin seems to be a very good drug to start with if you are suspecting meningitis. Thank you.
We don't have any other question. I think the forum can be opened. If you have anything else, we can take or we can conclude here. I leave it to the organizers.
Well, sir, we have some question in the chat box.
We have answered almost all of them. Not
Sure,
almost.
sir.
Okay, one is left. Catecholamine caused tachycardia due to pressure on the brainstem, then herniation happened. Yes, possible. That is possible. So these are things which are clinical in nature. Herniation, I have already said the ICP was raised. So one indicator that you have is the optic nerve sheath, which we saw was 6 mm in size, which is more than the 5 mm is the general cutoff. So 6 is definitely high. There are no questions in the chat box which we need to role of cerebral decongestive therapy. Oh, we don't know this. But this is one of my friends threw this question, but there is no recommendation about doing decompression, at least through lumbar puncture. Not needed. You only do it when there is a hydrocephalus. So if that is what I said, so that you should consider. Hydrocephalus can happen very rapidly in bacterial meningitis also. So you better look for neurosurgical intervention. Then cerebral decongestive therapy is recommended. Otherwise, not for raised ICP.
Well,
Expected curative time. Well, within 48 hours, if they're not responding, then look again. I mean, that is the time they improve also very fast. So you always look at complications, inappropriate drug, or maybe alternative diagnosis, some focus of infection if they are not improving in 48 hours. Medical decongestive therapy like mannitol, diuretic, glycerol, yes, you can use. Pediatric cases, drug preferred. Pediatric, we're not talking at all. We're talking about 12. I don't have any ideas. I mean, you can read up on your own, but would be similar therapies because all of these drugs can be used in the pediatric population.
And in addition, the pediatricians tend to add amikacin to their initial regimen of meningitis. What I've seen my friends do, they start with a ceftriaxone or a meropenem, vancomycin, yes, definitely, and maybe an amikacin they tend to add it. But I do not have any personal experience of treating pediatric meningitis. Thank you.
I think we have answered all questions.
Well, sir, it is actually a very interactive and good session we had. I would like to turn to the audience. If anyone have any questions, you can ask now. So we got one question in the chat box right now.
Amikacin, oh, already he answered. I don't have any idea. Please read it up for yourself.
See, I do not have any personal experience of using IV amikacin because I do not deal with pediatric patients. We have a separate pediatric unit. But what I have seen the follow-up orders, the drug chart they use. From that, I can infer that yes, they use amikacin quite frequently, and in fact, not only for bacterial meningitis. If they suspect sepsis, they tend to add with the even if with meropenem, they tend to add amikacin. And yes, I have seen them add amikacin in bacterial meningitis if they suspect bacterial meningitis before the LP comes down. So they add it in the part of the means what you say, the empirical treatment of meningitis in pediatric patients. They tend to add the amikacin.
I think we can conclude here. Just a concluding remark. Most important thing in any form of meningoencephalitis is establishing that there is either meningitis or encephalitis, whatever, number one. And number two is finding out the organism. Most important. So it is CSF, and then you then expanded CSF study. If it is available, get your BioFi test done, get your PCRs done, get your antigen card-based test done, whatever you have available. Imaging, if you have the liberty to take these patients to imaging, you can do imaging for looking at some signals of mainly complications. Nothing is going to add in meningitis in case of imaging unless a brain abscess is found. So imaging would only talk more about complications, and expect for an early turnaround with the patient. And if they don't respond in 48 hours, oh God, revisit your patient. Maybe you got to change things, or maybe you have to look for any complications. I think thank yous have also been received. I also say thank you. Thank you, Dr. Rao. Very nice interactive session. Thank you, Thames. You presented a very crisp case, very nice. A patient who has a cribriform fossa defect and develops meningitis. Always look for CSF rhinorrhea in some of these young patients who come with meningitis.
Sure, sir.
I thank the organizers. I conclude the session here.
Thank you.
Thank you everybody for joining.
Thank you, sir.
so much.
Everyone.
Thank you.
Thank you, everyone. It was a very interactive session and very interesting was as well. Thank you, everyone. Thank you. Have a good night.